Great. Thank you so much, Mariana. And everyone, thank you for enrolling in this webinar. And it's a pleasure to have you here, and looking forward to discussion. So let's get into what are we going to look at today? We're going to start out with general concepts, namely, what is the revenue cycle and what are we managing? We're going to look at impactors to the payment timeline, how quickly your money comes through. Impactors to the payment throughput, how much you're collecting of what you bill. We're going to look at some revenue maximization opportunities. How does revenue cycle management help you maximize your revenue? We're going to look at some metrics and KPIs for you to use to manage the process. We're going to take a look at some automation opportunities, and then we'll hit Q&A with about 15 minutes left to go in the hour. So let's get right into it. What is the revenue cycle? So the revenue cycle is what you need to do from the time you receive a client referral through the time you get paid for your services that you provide for that client. There are ways of maximizing that, which we'll talk about. And what you really want to do is you want to minimize the timeline to receive your money. You want to maximize the amount that you're going to receive. And you're also going to want to maximize the provision of authorized services, because that's one of the things that contributes to the amount of revenue that you get from your revenue cycle. So you want to be able to bill for all services. You want to be able to collect for all services, and you want to keep your clients safe and appropriately serviced. The payer sources typically in our industries, I know we have IDD providers on the call and home care providers. So typically, our largest payer in the services that we provide are straight Medicaid programs, waiver programs that are dedicated to the client base that we serve. Many states have gone to managed care. So the Medicaid has brought in managed care entities, MCO, MLTC, managed long-term care, and then they have programs within those the services that they provide. So you have personal care, you have dual eligibles, which are Medicare and Medicaid, you have consumer-directed programs. And then there's an opportunity for contracts within the home care side, excuse me, certified home care agencies that provide skilled services that are being billed to Medicare. They need the non-skilled services. You have long-term care facilities and hospice. You can do some staffing. You can send folks in there. Workers' comp, certainly. Veterans Administration. And then there are nonprofit community service organizations that support the population segments that we support and that are specifically designed for that. And they will often contract out for the services that you guys provide. And then you have the client responsibility or full private pay, which could be the client or the family. There could be advocacy associations that support that. So Muscular Dystrophy Association, Alzheimer's Association, things like that. Trusts and guardianships, which could be attorneys or family members that are there to support their clients. And then, we have long-term care insurance, of course, and there is a little-known pension for home care called the VA Aid and Attendance Pension that you can Google and find out more about. What impacts the timeline then? What impacts how quickly we're going to get our money? Certainly how quickly you collect your time, and then how quickly you get your bills out the door. And then, how do you resolve held billing, system edits, rejections in EDI, et cetera? You want to make sure that you get those resolved as quickly as possible. You want to take steps to minimize them so that your workload is reduced. But you want to be checking that every time you send bills out the door. How you bill, very important. Are you billing on paper or are you billing electronically? Payer contracts typically state timely filing and timely payment is for bills received electronically. You have proof that they received the bill. Paper is much more nebulous. You want to be able to submit clean claims and invoices. So you want to make sure that they meet the payer requirements, coding is proper, all of the elements that need to be on the bill are on that bill. How are you getting your payments? Are you getting them transmitted directly into your bank versus paper checks? Can't tell you how many times we've done reviews for clients for their revenue cycle operations, and I've walked around at night and just opened up drawers on people's desks that are billers and collectors, and I find live checks in the drawers. They never went to the bank. So certainly the processing time for the payments, you want to make sure that everything makes it into the bank. You want to make sure that you're posting everything right away. So if you can get an electronic remittance advice that you can upload into your system, that allows you to get things posted. It allows you to see your denials quickly and start to react and respond to discrepancies, denials, etc. Then we have the volume of denials and exceptions. So you want to try to minimize your denials. You want to look at your denials and you want to ensure that they don't recur. So what can I learn from what is being denied? What's going on in my operation that's causing these denials? And let me swim back upstream through the revenue cycle to get those issues resolved so they don't recur going forward and they don't recur in future situations. Certainly in terms of verifying the hours that are reported. So in the EVV world, electronic visit verification, and which is increasingly being required on both the home care and the IDD side, you want to make sure that all of the time that's coming in are verified. You want to minimize the number of people who are not using the system, which means that they're having to hand in paper. In the IDD world, typically in the facilities, you're going to have some sort of a timekeeping system. You want to ensure that the employees are reporting their time correctly. They're charging the right cost center. They're reporting the correct activities. They're doing everything that then your billing and accounting system can utilize that data without it having to be touched by human hands. So training is a very important aspect of that. I know our IDD clients are continually training their staff and reviewing how the timekeeping process occurs and ensuring that everyone knows what they're supposed to be doing. The metrics that you can follow, there are reports that will come out of a good agency management system. Aged hours unverified, billed versus paid hours, things like that. So monitor your metrics in that area. And we'll talk more about metrics later in the presentation. Claims not billed. So a good billing system will hold claims that are not appropriate for billing to avoid denials going forward. So certainly on the front end, before the claims are created, you want to watch your timekeeping discrepancies. You want to process your paper timesheets. You want to ensure that your paper timesheets agree with the schedule. You want to resolve any visits that are unconfirmed. So, is there a no-show? Is there, did something happen where the time didn't come in? And if there was a visit that was actually provided or a service that was provided in a facility, et cetera, and the time wasn't collected, why? So that can be tracked by coordinator in the home care world. And then you want to look at errors. So certainly in the IDD side, activities being reported correctly, the correct cost center, correct facility, et cetera, tracking all of that, because if that comes in clean, then that's going to enable your claims to go out quickly and clean. As I mentioned, there are system edits. So certainly the system will watch authorizations, providing services after the end date of the authorization, issues with codes, so monitor your reports. There are held billing edit reports that are produced by most comprehensive agency management systems. So you want to monitor those, run them on an ongoing basis, and make sure that everything is being addressed. And you want to, even if there are things that are waiting and need to be resolved, if you're up against the timely filing deadline, release them anyway. So the claim will go out incorrectly, it'll get denied, but at least you won't run out the clock on timely filing. and you can always submit a corrected claim. Throughput. So throughput is how much am I getting paid? How much of my revenue am I getting paid for? Certainly complying with your contract, using the correct codes, getting your claims out the door clean, submitting your claims timely, submitting them to the correct payer, and we'll talk about that a little later on. Managing your authorizations, providing services according to the authorizations on the correct day, the correct time, the correct number of units, etc. And then addressing service issues. So in the private world, people will call and they'll say, hey, you know what, I wasn't really crazy about the service I got, or it wasn't according to what I ordered, or I have a question, etc. Question about my bill. So resolve those, address those quickly, and that will enable you to get paid 100% for all of the services that you provide. So let's talk about the front end, which is contracts administration. Every payer will have a contract. If you're not contracted with that payer, you will need to have a specific case agreement. So how do you manage all that? In the world, we have so many contracts that are out there. So what we use is a form, and I can send this to you if you reach out to me. My contact information will be shared. It's actually phil.feldman@sandata.com. Very simple. We have a spreadsheet that you can enter your information into. You can then track, did you receive your executed copy? Absolutely very important to have a fully executed copy of your contract on hand. If you have signed it and the payer hasn't, there's a very good chance that they're going to deny claims and say, hey, we never executed that contract. What's the exception and expiration date? And what are the terms? What do you need to know for timely filing, timely appeal, timely payment, and what are your rates and codes that are appropriate in that contract? So this can be sliced and diced and sorted for what are my upcoming expiration dates? What do I need to reach out to the payer for a renewal for? What's going on with my rates? Who's giving me my best rates? Who's giving me my worst rates? So you can get a lot of management capability out of utilizing this Excel worksheet. Let's talk about eligibility. So eligibility, enormously important. What payer am I billing for this client? So absolutely a very high dollar risk. So if a payer is taking 6 weeks to turn around their payments to you, and you billed the wrong payer, you've billed for 6 weeks to the wrong place. Now you have to scramble to get those 6 weeks billed to the right place before timely filing runs out. So you want to obtain your insurance ID, your Medicaid ID prior to admission. Make sure you check that eligibility on an ongoing basis. You want to check on the 1st and the 15th of every month, because that's when payers typically update eligibility. It's when Medicaid typically updates eligibility. So people come in and out of Medicaid, and if they're with a managed care organization, you have two things to deal with. You're dealing with their Medicaid eligibility, and then which payer have they selected in that managed care world. So they can switch payers. You need to know the rules in your state for when they can switch payers. And if they do switch and you learn that they switched and you're a couple of weeks down the road after they switched, you have to go back to the new payer and get an authorization, which may be retroactive to the date that they switched. And always to remember, and if you contact customer service at a payer, an authorization is not a guarantee of payment. They have to be enrolled with that particular payer. So if they disenroll with that payer, that authorization that you have is null and void. So let's look at authorizations. After eligibility, this is the second largest denial category. So your intake staff, your coordination staff, they should know how to read an auth. They should know and understand the data elements in that auth. They have to verify what's in that auth. So that it has to agree with the service that's being provided. It has to agree with the schedule. The units have to agree with your contract, the type of units. So, and they should recalculate the units. I've seen plenty of times where there are errors in the calculation of the units on an authorization. Somebody just did the math wrong. So it's not an automated process typically. Some human being had to take the number of visits or the level of service being provided for the period of time and calculate the number of units in that auth. And then you have to watch out for changing authorizations. You have to watch out for expiring authorizations. If your client is hospitalized or comes off service, comes back on, gets reassessed, a new authorization may be needed. So, we talk about procedure codes, modifiers, the member ID, all of that. You have to watch out for incorrect or missing information. As I said, check the calculations, set the case up correctly with the right codes. If you need to use modifiers, use them. And then monitor reauthorization. So monitor when things expire. A good system will generate an expiring auth report in advance of the expiration of authorizations. Typically that's set for 30 days. Get your process started to apply for a reauthorization. Some providers have told us, this comes from different states. So you have to know, my point with this slide is you have to really know the rules in your state and the rules with your payers and what their practices are. So very important to know and understand that in terms of authorizations. When in doubt, absolutely call the payer. Rectify issues up front right away, before services start if possible, or as soon as possible after the start of service. Okay, let's talk about actual filing of the claims. You've provided the service, collected your time, you have your authorization, etc. So number one, always be familiar with the payer's billing manual. That's the rules and regulations. Bill on the correct form type. So that could be a UB, it could be a miscellaneous format claim, CMS 1500, depending on the type of services. Even if you're billing electronically, there's a form and format for that file that's going out the door that needs to conform to what the payer is looking for. Bill consistently and on time, particularly in the private pay world. People like to get their bills timely. They want to know what they owe. The sooner they get a bill, the sooner they'll be prepared to pay it. Make sure that all of the correct data is in the right format, in the right field. As I always say, bill electronically and always get paid electronically. I wanted to go a little bit over EVV and claims aggregators. More and more states are requiring EVV. That will be required at some point in time over all 50 states. And more states are moving towards managed care, and they're inserting aggregators into the process. So here's a scary chart. This is North Carolina. So you were dealing in, North Carolina recently switched to managed care. So on the upper right-hand side, you've got 4 payers, actually a total of 5 payers for home care services and 5 payers for IDD services. And they're going through, in order to deal with the payer, you need to go through an aggregator, which collects it. It is used to provide you with your case placements, your authorizations, your plans of care, and ultimately your payments in a lot of cases go through that. So, in order to deal with the payers, you have to go through an aggregator. It's a much higher level of effort, creates a lot more effort in the process, and it slows everything down. So some advice, basically aggregator platforms are actually agency management systems and have many of the same edits as your system. So the data now has to agree, instead of just in your system and the payer's system, it has to agree across 3 systems. So you need to keep the data in sync. You need to try to avoid data being edited out and transactions being edited out in the aggregator. So something that might have gone out clean to the payer in the past, if there's a data discrepancy in the aggregator, that will cause that claim to be held up. EVV matches, they're done in different states and different places. Sometimes they're done in the aggregator. Sometimes they're done at the state level. Sometimes they're done at the payer level. You need to know the rules for that. You need to know, when should my EVV go out? How far in advance of my claim? So if you are correcting your EVV and submitting a corrected claim, and the corrected claim goes out first before the EVV is on hand, then that will kick out as a mismatch. So the big thing here is you have to understand how the process works in your market, in your geography. And this is more things. So resolve your own edits, then transmit your data to the aggregator. One thing important is, since the aggregator is dealing directly with the payer, the aggregator trumps all the rules. So you have to make sure that you're following the rules for the aggregator in order for your claims and your EVV not to be held up. Also, very important, utilize aggregator customer support. That's probably the most important thing here. They all have pretty robust customer support systems. Reach out, call them as soon as possible, get the help that you need. Let's talk about payments, the back end of the process. Certainly, like I said, you want to enroll in electronic payment. Know when your check run due dates are for billing. So time your billing with the check runs. So for instance, we know for IDD in Ohio, Department of Developmental Disabilities, their requirement to make the next check run is Wednesdays at midnight. So all of our people are pushing to make sure that we get our claims out by close of business on Wednesday to make the next check run. Different services may be on a different payment calendar. So you need to know who's getting your claims, what's the payment calendar for that specific type of service. Post your payments promptly, as I said before, so you can deal with discrepancies. Reconcile your payments to your invoices. Follow up again on discrepancies, because that may result in, it may expose the fact that you're billing at the wrong rate, or the payer has the wrong rate in their system, etc. Denials, absolutely review them as quickly as possible. We take our denials and we have a collections group that works them. So we peel the denials off from the payments and get them into the collections group. What are denials? Certainly eligibility issues, authorization discrepancies on the IDD side, typically provider type disconnects. So we've seen situations where transportation was provided, but the service that provides the day service reported that client absent that day. So that's going to get denied. So you might need to coordinate with other providers in that service continuum. Watch for expired authorizations, and watch for services that you're providing that are either not authorized or not even covered by the client's payer. Always appeal promptly. Every contract will have appeal deadlines. Always appeal promptly. So then how does revenue cycle management support your revenue and maximize your revenue? Certainly minimizing denials, minimizing write-offs, et cetera, et cetera. But there are also other things that are surfaced. Certainly underserviced clients, and we'll talk about that a little bit more. Certainly your rates, monitoring your rates, knowing when increases are announced, watching out for contract amendments, watching out for state. There's a lot of minimum wage increases that have gone out. Announcements came out from the state. There should be a minimum wage increase from the payers that coincides with the minimum wage increase that's required by the Department of Labor. If that comes through late, look for retro pay. So resubmit your claims. Look to the payers to say, hey, this rate was effective on X date. How am I going to get paid for that difference? And then watch your short and overpayments, because like I said, it could mean that you are underbilling, overbilling, or the payer is underpaying, or sometimes even overpaying, and then they're going to take the money back later on. Underserviced clients, big revenue opportunity. So if it's difficult to staff cases, difficult to staff in your facilities, your clients are going to wind up underserved. So you're going to lose revenue as a result of that. But the other issue is that you're going to have clients that are, our mission is to service our clients. You're going to have clients that are underserved, unhappy, and potentially at risk for adverse events like falls, et cetera, hospitalizations. and that's potential liability for you, and reputational. So there are reports that will come out of a good system. These are some of the reports. I know when I ran a home care agency, these are the things I looked at the most. And I certainly wanted to know about every client discharge, when it occurred, and why. Let's take a look at some metrics. So these are the big name metrics that we always monitor. Certainly we monitor the aging report. I'll show you a schedule called billed versus deposits versus applied payments. That's very useful. Days sales outstanding. For you finance folks on the call, you will understand what that is. We'll walk through that. How long it takes you to collect. So we can take a look at a graph that shows that. Held billing, what are the claims that haven't gone out the door? Unconfirmed visits, rejections, EDI rejections, denials, tracking by type and by payer, and expiring and expired auths. Those are typically the big name metrics and KPIs that you want to look at and manage. Aging report, absolutely. That's going to help you see, what claims are still outstanding. As long as you're posting your payments timely, whatever is left out there are things that you have to follow up on. They could be entire claims. They could be partial payments, etc. They could be overpayments. So, but then you have to know what your system does with unbilled claims. Are they in the aging or are they not in the aging? So if your system is holding claims due to edits, you want to make sure that if they don't appear in the aging, that's something else to follow. Billed versus deposits versus applied. So this is an interesting schedule that lists by month on a rolling year basis. What did I bill in that month? What are my bank statement deposits in that month? And it doesn't necessarily apply to the billing, but you want to see it on an ongoing basis. You want to run it, you want to see that you're roughly in the 99 to 100% range on a rolling average basis. And then take a look at how much was applied that month in your cash receipts journal. Did you apply all of the money that you received? If not, what's the reason for that? So, this is an agency that is only collecting less than 90% of what they're billing out. Certainly something that needs to be looked into, what's going on with that. Certainly in their payment posting, you're seeing that they're not posting everything on an ongoing basis. So they did some catch up, etc. So this is a nice overview from a managerial perspective. And in general, how is your revenue cycle department performing? Days sales outstanding is it's also known as your average daily sales or billing in accounts receivable. So it's how much do I bill on an average day, and how many of those days are in my accounts receivable balance. So you're looking for lower DSO, which means your money is coming in more quickly. If you have a higher DSO, your collections are slower. So typically in the Medicaid world, it's very low because you're getting paid pretty quickly unless you're being denied for a lot of things. Managed care world, it's slightly higher. We typically see in a mixed world, maybe 45 days outstanding, a 45-day DSO. And then, I always like to ask my department, if our contract says that clean claims are paid in 30 days, why isn't our DSO 30? And, typically it's because of denials, it's because of other issues and things like that. It's very rare that you're going to see a 30-day DSO. An example of the formula, if we have an agency that's got $100,000 in accounts receivable, they're billing $1 million a year. Based on this formula, the DSO will be 36 days. So this is just an example of how it works. Certainly metrics to follow: percent collected by aging bucket. So what's the accounts receivable at that age based on how much did we originally bill? And that's something that can be tracked. If you're looking to manage that, here's an agency that started out managing it and had a certain level of collection that was not appropriate for them, not acceptable to them. They put some steps in place. They compared it again 6 months later, and they're finding that their percentage paid at every aging bucket is higher than it was, so they know what they're doing is working. This is held billing. This can be done by coordinator, by reason, what's going on with it. And this is another agency that tried to manage things over a period of time and actually achieved reductions. So, develop, figure out what you want to measure, put the metrics together, use Excel, use report filters from your system, try different reports, filter them in different ways, see what comes out that works for you, then start to track them. Keep your eyes on them and watch for results. Let's take a look a bit at automation. So a lot of, there are a lot of opportunities for automation. Certainly your agency management system is designed to automate the process. A good system will provide certainly electronic visit verification, will integrate your revenue cycle management process. So your scheduling, your authorizations, all of that tracks into your electronic visit verification. So what's received from the field is bumped up against your schedules, which are already coordinated with your authorization. It's designed to produce claims quickly. It's got an accounts receivable in there. It'll produce reports for you, get claims out, and allow you your contract compliance. So, and then the reports, services that were missed, clients that were underserved, all of that is all integrated in a good system. Let's talk about, also in terms of a good system. So with electronic visit verification, you're not dealing with paper anymore. Enormous opportunity. Just think about that. So it's more convenient for your caregivers, your employees in the field. They're reporting in electronically. There are apps available on the cell phone that they can use to report their time. If they're in a facility, if there's an electronic method of them clocking in and clocking out, that's the way you want to go. It automatically verifies everything against the schedule. You're not waiting for timesheets. They're not losing timesheets. You don't have to send them out. New copies of new blank timesheets. They don't have to come into the office to pick them up. Employee satisfaction grows. Internally, you have basically a paperless system. So for audits, for all of that, you're getting all of your information right out of the system. You don't have your storage needs. Things aren't getting lost. You're not worried about unreadable documents, unsigned documents, et cetera, et cetera. So all of that integration is going to allow you to get your claims out the door more quickly. It's going to pre-edit and review your claims to ensure that they're going out clean, because your schedule is bumped up against the authorization, and it basically advises you if you're scheduling outside of the authorization. It's reducing your denials and claims rejections. So I think that's it. We're actually a little ahead of schedule, so we have time for a lot of questions.
Great, Phil. This is Mariana. I'm keeping track.
Great.
Can you hear me okay?
I can hear you.
Great. So here I'm going to go in order of received. Here's your first question. For the EVV requirement, is there a program that providers can inquire about?
For the, well, certainly there are many vendors in the business. Sandata is one of them. We have a great system. Sandata was the first company to come on with EVV some 40 years ago. So they were a pioneer in the industry. And, our system is very good. Certainly inquire about that, via the Sandata website. There are other vendors out there. You can do your comparison, get demonstrations. I would recommend that you get a demo, and they will walk you through that. Also, I want to say that there are different EVV models in different states. So there's the closed model and the open model. The closed model is where the state dictates what EVV system you need to use. So they put something in place, they hire a vendor, put that system in place, and you have to use that system. And then that system comes with varying capabilities. So it creates risk. There's the open model, which is the universally preferred model, which allows you to use any vendor that you want to use, as long as that vendor can provide the basic data elements into the state system. So sometimes that requires an integration from your vendor. You know, sometimes the vendor that the state uses is actually a competitor of your vendor, but these two systems need to integrate. And there are specifications for that. There's an enrollment process for that, et cetera.
Great, thanks, Phil. Question 2. Any advice for DOS/collections when outsourcing billing and collections?
Sure, absolutely. Well, that's what we do. So in terms of advice, certainly talk to varying vendors, find out their track record, find out their performance. There are plenty of vendors out there that all they do is bill and collect, and you know, there's very little communication. What you want is a vendor that is going to bring you back intelligence on what they're seeing. So what are they seeing in denials? What are they seeing in rejections? You want a vendor that's going to work with you on an ongoing basis. When we start working with a new customer, certainly we're communicating with them daily until the transition is running smoothly. We have weekly calls in the beginning with their management to ensure that everybody knows what's going on. We're getting issues resolved and rectified. We're providing intelligence. We move then at some point when everyone's comfortable, we move to monthly calls and we go over progress, we go over performance, and all that. We're providing regular reports. And the other big thing is my preference would be somebody that works in my system. So I don't want, if I'm a provider, I don't want somebody taking data from my system, pulling it into their system and working in another system. We work in whatever system that you are in. So if you want to go and press a button and run a report, you can. If you want to end the agreement at some point in time because it's no longer serving you in what you were looking for, you still have and own all of your data, and your data is up to date. You don't have to worry about starting from scratch all over again.
Great. Here's a slightly longer question, Phil. It says, as you know, speed to pay is paramount. The large institutions are able to negotiate payment metrics with payers to avoid delayed reimbursements when negotiating payer contracts. In the home healthcare world, are you aware of any strategies for agencies that could help reduce the time from payment to patient to payment? And then he clarified, the assumption is that the claim is clean.
Well, certainly, if they're not following their contract and paying you timely, that's something you want to bring up with them. In terms of on a broader basis, value-based payments is something that's coming into play. And in terms of outcomes, managing your outcomes, developing a relationship with the payer. The payment cycle at a payer is pretty mechanical. So there isn't a lot of control that the relationship people at the payers have over the process. But certainly, yes, absolutely, if the assumption is clean claims, the claims need to be clean. The claims need to go out timely. So the sooner you get them out the door, so you can be within timely filing. And if your timely filing is 30 days and you're billing your claims out at 20 days, and you can pull that back to 10 days, absolutely, you're going to make an earlier check run and you're going to get paid sooner. So the sooner you get the claims into the cycle, the fact that they're clean, and the higher percentage of your claims are clean, the sooner that you get paid. Now, sometimes claims get hung up for various reasons. Sometimes they get lost in the system or whatever, but that's why you want to post your payments quickly, and you want to see what's still outstanding, and then follow up through the payer portal You can look up your claims, you can see what the status is of that claim and what's going on with it. And if it requires follow-up, then follow up at that point.
Great, thanks, Phil. And by the way, throughout your presentation, you were getting many requests to send forms on. So we'll make sure that the forms go to everybody participating on this webinar.
Fantastic. And I'm happy to send the templates for those, the Excel templates
Great.
for the forms.
Phil, next question. Please tell me which account receivable report is the best to use. There are many to choose from. I want to use this to see what claims have not been paid.
Definitely the simplest is the aging report. And a good system will allow you to set the dates that you run the report for. They will allow you to set the aging buckets. So it could be 0 to 30, 31 to 60, 61 to 90, or you could do 0 to 60. You can merge buckets and all of that. Certainly you want to look at things that are 60 days old and over, because that's really where the cash flow impactors are. You also want to track what's the percentage of my total AR of each of the buckets and trend that out. So if you're seeing that your 61 to 90 bucket is growing in percentage over time, why is that happening? Dig into that. What payer is driving that? And then, as I said, swim back up in your revenue cycle stream to see what the root cause is. Sometimes it's the payer, sometimes it's you.
Great. Phil, we have someone from Illinois, and she asked, I've been trying to get a welcome kit from Sandata. How can I secure this?
Phil.Feldman@sandata.com. Send me an email and I'll get it to the right place. I don't know offhand where to go with it, but I will find it and get you what you're looking for.
Great. And the next question, it has to do with an issue of not releasing claims timely that are due to documents, especially the FTF for the Medicaid and Medicare payers for home health care.
Yeah, documentation is tough. So, in the Medicare world, you have, you have your physician contact. You have nurses' notes in in any situation. Some payers require timesheets to be attached, paper timesheets. It's an issue. It's paper, and anytime you have paper, it's going to slow the process down. Now, if you're sending out your claims electronically through EDI, many of the clearinghouses can handle scanned document files, but still you have to still collect the paper and ensure you're getting it. So you need processes to get that paper into your location, which is follow up, follow up, follow up.
Great. And here's another geographic specific question. Participant says, what is the model for EVV for the states of Pennsylvania and Rhode Island?
I believe Pennsylvania is an open model state that's been around for a while in terms of EVV. Rhode Island is just going to EVV. I don't know offhand what the model is, but I can, Marianne, I can send you some information on that.
And Phil, that makes me curious, how different are the models for the various states around the country, the EVV models?
They vary by state, and they vary by how the data is collected. So, states are gradually moving to the point, and this is required, where the EVV is matched against the claims. And that could happen at various different points across the process. So that can happen in Medicaid, or that can happen in the aggregator, or that can happen at the managed care payer. It all depends on the state. And then you have your open and closed models as well. So, and I will also say that some models, every model will provide a free EVV platform, and I would guard against using that. I would caution against using the free platform because it doesn't really come with any capabilities above and beyond collecting the data. So it doesn't do much to help you manage your process, and it may or may not be integrated with your system.
Wonderful. I think we've gone, Phil, through all the questions that have been received thus far. As I said, you've gotten multiple requests for forms. One quick one here, hold on. Once that data goes live, is some data going to communicate to claims directly? And what about when you have caregivers in a rural area that are unable to clock in and out? What does that look like when making the corrections to the exceptions?
Okay. I'm sorry, Marianne, can you repeat the first part of the question?
Yeah, let me read that again. Once it says, once that data goes live, is that data going to communicate to claims directly?
Okay, so it depends on the model. So it depends on what the payer is asking SanData to do. So if it's a state like Colorado, where SanData is only handling EVV, claims are going through another, another portal. If the payers have requested SanData to handle the claims, then yes, SanData will handle and absorb those claims. So, for instance, North Carolina, in the chart that I showed, SanData is receiving both the EVV and the claims for from North Carolina providers to send up to North Carolina Medicaid. But the MCOs, it's a different model than that. So like I said, I can only say it depends. It depends on the state. So you need to get familiar. States and vendors have very, very robust websites. So if you just Google EVV and the state, you will track through and just keep following the path towards more and more detailed information. And then there was a second part of the question, Mariana. I'm sorry, I remembered it when I asked you what's the first part.
Yes,
So now
here we go. And it says, and what about when you have caregivers in rural areas that are unable to clock in and out? What does that look like when making corrections to the exception?
Okay, great. So in rural areas, firstly, in the old days when people were clocking in and out telephonically, sometimes the client would not allow you to use their phone, or they were on the phone. It was very unreliable. Now with cell phone applications, and this is an app that SanData provides that gets installed on the caregiver's cell phone. It does not share any data from the phone. It operates completely independently of the phone. The phone is just powering the app. Okay, if there is no connectivity, if they're in a mountainous area or something like that, or very rural, where they don't have cell towers, the data will be collected in the cell phone. As soon as they get back to an area with service, that data will automatically upload the original data that was collected when they were in the service location.
Great. And while you were talking, someone said, I have this problem in Tennessee all the time.
I can imagine. I can imagine.
I think this is the last question. Do you still provide the device for those patients that don't have a phone?
The agency can obtain and provide devices to the clients. There are also devices that can sit in the home. And then in some cases, states provide grants and things to be able to provide devices to the caregivers. So once again, it depends. What we see, it just depends on the location. So we assist states in obtaining devices and then provide those devices to the providers, providers, many providers in states that don't do that are going out and getting the devices themselves.
Great. One person is talking about what is available in Arizona through the Arizona Healthcare Cost Containment System. What do you know about that, Phil?
Nothing.
Yeah,
But I can find out. Arizona Cost Containment System.
yeah, he said,
Okay.
he's asking, are they handling the claims? The same with rural area in Arizona, even the phone, no cell tower.
I will find that out, and Mariana, I will send you a note on that.
Great.
So we have folks in our organization. We have the state contract in Arizona. Actually, Arizona and Hawaii are on one contract. So we have that contract, and we have people in our organization that are very knowledgeable about how things work in those states.
So I would say, Connie, who posed that question, if you'll just connect with me at my Anchor address, mnork@anchor.org. After this, I'll make sure that you and Phil connect so you can get the response you're looking for.
Great. Thank you, Mariana. Thank you, Connie.
Phil, question is, with the devices not logging the information correctly, who is or what is best resource for clearing the billing?
If the device is not logging
The
information correctly.
What's the best resource for clearing the billing?
Well, from a mechanical perspective, number one, you're going to want to contact the client to confirm that the service was actually provided and what are the in and out times. And then you're going to want to document that. So the way I would handle it is I would do what I need to do to get a bill out the door. As long as I had a verbal conversation with the client and they said, yes, this person was here, you can, in a good system, you can manually verify and confirm that visit to get a bill out the door, and then go back and back it up with paper.
Great. Someone asked, do you have the contract in California?
Yes, we do.
Great. So that's helpful to James on this call. Another person asked, we have timesheets, but the EVV is difficult to work with.
I would need more information on that in terms of what the difficulties are with EVV. Should be a lot easier. If it's working correctly and everybody's doing what they're supposed to do, it should be a world easier, different than easier than timesheets.
Great. That is the last question, and we're coming down to the end. So what I want to do, Phil, is give you the opportunity for any last words or remarks before this webinar is over. Based on some of the questions coming in, you're getting a sense of where people are, how they're leaning. Any parting words of wisdom that you can continue to share?
Sure. I think really it's really all about the overarching thing here is being thoughtful. So doing your research, understanding the process that you are working with, whether it be simple or complex, being communicative, communicate with the payers, read their manuals, provider support. If you're not getting the answer that you need, call again, upline it. Your state association can be helpful. Your vendor, your agency management system vendor can be helpful. So use all of the resources at hand, but certainly don't let things languish. And continue to measure and monitor, but by all means continue to follow up.
Phil, that's great. I think those parting words of wisdom that everybody can benefit from. Phil, thank you so much. As I said, you have had a lot of comments coming through, a lot of thank yous, a lot of requests for forms. So I think your presentation and the sharing of your expertise has come at a very appropriate time. And I know everybody on this call, the dozens and dozens and dozens of people are very grateful. So fantastic. Thank you, Phil. Thank you, Shandata, for sharing expertise and for sharing Phil with us. And I would say, Phil and everybody, have a wonderful day, and thank you for joining us.
Thank you. Take care, everyone. Thanks a lot.